Development of continuous curvilinear capsulorhexis technique has significantly contributed to the safety and effectiveness of phaco-emulsification. But that does not mean that it is an unalloyed blessing. CCC has its own share of complications. In this video we would like to discuss some of the ways to avoid such complications. You can find the links to other videos on similar topics in the description of this video. You can also find the links to the instruments used in these steps in the description of the video. Small continuous curvilinear capsulorhexis. The refractive shift. If the CCC is too small, IOL may be pushed posteriorly by excessive anterior capsular overlap, thereby causing a hyperopic shift. If it is too large, the optic of IOL can shift more anteriorly, resulting in a myopic outcome. If the capsulotomy is decentered, the IOL optic can be tilted or decentered, resulting in astigmatism or compromised visual acuity. Small capsulorhexis 4.5 to 5 mm has been reported to be associated with less wrinkling and less PCO when compared to large rhexis. In cataract surgery with PMMA lens, a small rhexis with complete capsule or optic overlap is preferable in reducing posterior capsular opacification. Difficulty in doing phaco. Even for an expert phaco surgeon. During phaco surgery, it makes the breaking of nucleus difficult and increases the stretching of anterior capsule edge. After surgery, a small capsulorhexis is more likely to contract rapidly and cause capsular contraction syndrome. Size of rhexis remains an important determinant of strength, integrity, and transparency of capsule. Studies in animal models have found that lens fiber regeneration is faster in smaller anterior capsulotomy as compared to larger ones. Although a 5.5 mm rhexis may be the perfect size of the capsulotomy, different conditions may warrant different sizes. For dense cataracts, a larger rhexis is preferable. Slightly smaller rhexis in posterior polar cataracts is better than a larger one. Later is done to ensure that lens implantation in sulcus can still be done, even in the event of a posterior capsular rent. Posterior capsular rent. The complication that every ophthalmologist dread. Anterior capsular radial tears can occur with CCC. If the CCC margin is stretched too much, the rhexis tears can occur during any stage of surgery. But is most commonly seen when the actual rhexis is done and a radial tear occurs. It is a well-known fact that radial tears increase risk of a capsular rent. Early recognition and appropriate management of these tears prevents extension to the posterior capsule and subsequent capsular rent. In the event of occurrence of peripheral extension of tear, rhexis forceps can be used to change the direction of tear. By holding the torn flap of the capsule as near to the base and pulling it toward the center of the pupil, peripheral extension of the tear can be prevented. Hope you find the video useful. Please let us know in comments the factors you think are responsible for complications associated with CCC. Please let us know the other topics on which you would like to see similar videos. Check the description below for a link to other useful videos and instruments mentioned in the video.